Good evening, everybody. And we are here with yet another challenging aspect of obesity, talking about obstructive sleep apnea. So, currently, we are going to talk about assessment of a patient with suspected sleep apnea. Now, why should anesthesiologists focus on obstructive sleep apnea at all? Now, obstructive sleep apnea has proven to be one of the most dreaded coexistent problem, which is very common in obesity. It is almost 80 to 90% of obese patients have been found to be suffering from some degree of obstructive sleep apnea. So it is extremely important for us to be prepared to deal with patients and whenever possible prevent all possible complications and comorbidities that might come as a package with obstructive sleep apnea if we are not prepared. So, what are we going to learn today? What are the anesthetic challenges in patients with obstructive sleep apnea? How to make the anesthesia experience safer for these patients? Which patients are at risk? How do we select these patients? And which is the best form of anesthesia for them? And what is the journey of an obese patient after surgery? Now, it is not new. We know that anesthesia literature is studied with, research articles which focus on problems that come with obstructive sleep apnea. So, one of the papers, which is like a very large, covering a very large patient database of more than 1 lakh patients, which was studied over 4 years. Now, this is only one of the studies, found that the post in the patients who have any degree of sleep disordered breathing, the post-operative outcomes are directly related to the severity of sleep apnea. Now, the type of problems like, arrhythmias, respiratory failure, requirement for an unplanned non-invasive support to the ventilation, and problems like reintubation in the post-anesthesia care unit are all associated with have been found to be much more in patients who suffer from some degree of sleep disordered breathing. So we must find out ways by which we should be able to detect sleep apnea in patients who are otherwise not diagnosed sleep apneics. So pre-op assessment and preparation of a sleep apneic patient. So the main purpose of pre-op assessment is that, of these sort of patients is that, we need to find out those patients who have undiagnosed OSA and so that we are able to preoperatively initiate CPAP therapy for these patients whenever possible. And we should be able to curate the post-operative monitoring, which is suitable for these patients. So most important patient aspect is to detect sleep apnea. Now, we come across different types of patients in our practice, those who have diagnosed OSA and are being treated. Those who are diagnosed OSA, they are partially treated or are non-compliant with the treatment that has been offered to them. Then third category of the patients, which is the most important as far as this webinar is concerned and our practice is concerned, is those patients who are suspected of having OSA. So whenever we come to know any of these patients, we need to find out what is the sleep apnea status. Is the sleep apnea getting controlled? Is the patient compliant? Is there any improvement or response to the treatment that patient has been subjected to? Now, the response to the treatment could be multiple. Non-invasive support to ventilation is one such thing. A lot of times these patients are full of extracellular fluid, their lungs are full of fluid, they come in failure, and they have massive pedal edema. So these patients, whenever we detect them ahead of so assessment of the status of sleep apnea is very important. Then not only that, assessing the anatomical and physiologic abnormalities, status of coexisting diseases, nature of surgery, type of anesthesia, need for any post-op opioids, patient's age, everything has a bearing on the outcome and how the patient responds to the anesthetic management in the perioperative period. So let us see this case scenario.
हेलो, नाम क्या है आपका?
हिमांशु कुमार से।
और कौन से एज ग्रुप क्या है आपकी?
35 का।
ठीक है, कौन सी सर्जरी के लिए आए हिमांशु?
गोल ब्लैडर के लिए।
ठीक है, ये पहले कोई सर्जरी कराए हैं
जी
आप?
मैम, अपेंडिक्स का सर्जरी।
अच्छा, कोई बीपी शुगर थायराइड की दवाई लेते हो?
बीपी की दवा लेते हैं।
अच्छा ठीक है, तो हिमांशु ये बताओ, जो रूटीन आपकी एक्टिविटी है, घूमना फिरना आराम आराम से कर लेते हो? कभी ऐसा लगा सीढ़ियाँ चढ़ते सांस फूल जाती है? कभी कभी लगाता है। अच्छा, और कोई घर वालों ने कभी बोला तो कि नींद में तुम बहुत खराटे लेते हो, ऐसा हुआ है?
जी।
ठीक है, सुबह जगते हैं तो कैसा फील करते हैं? आपको लगता है थोड़ा सर में भारीपन सा महसूस हो रहा है, रात भर नींद शायद ठीक से नहीं आई, ऐसा लगता है क्या?
कभी कभी लगता है।
हर हमेशा नहीं लगता, कभी कभार लगता है।
जी।
अच्छा ठीक है, कभी ऐसे नींद से उठ के जग के बैठ गए हो कि मेरे को सांस नहीं आ रही है, ऐसा कभी हुआ है?
नहीं,
ऐसा कभी नहीं हुआ है। ठीक है, बीपी की दवाई करते हुए काफी टाइम हो गया है?
3
साल हो गए हैं। ठीक है, एक ऐसा करेंगे, इनका ना एक नेक सर्कमफ्रेंस करा लेते हैं।
गुड मॉर्निंग डॉक्टर संगीता।
हाय, गुड मॉर्निंग।
हाय, गुड मॉर्निंग।
गुड मॉर्निंग डॉक्टर अभिषेक। एक पेशेंट आए हुए हैं, मिस्टर हिमांशु। ही इज 35 ईयर ओल्ड एंड ही हैज कम फॉर ए गॉल ब्लैडर सर्जरी। तो अभी मैंने जस्ट इनकी पीएससी की। So what I doubt is hypertensive. I feel he has a OSA component too.
Okay, what is the stop bank score?
Stop bank score will be around like 6 out of 8. He has snoring. He feels tired and early morning headaches. बट ऐसे ऑब्स्ट्रक्टिव उसको एपनिक स्पेस तो ज्यादा नहीं बता रहे हैं, बट हाइपरटेंसिव भी है। नेक्स्ट सर्कमफ्रेंस मैंने चेक करी थी तो अराउंड 41 आ रहा है सर।
Okay.
तो आई विल 6 out of 8 है सर।
Okay. And any problems in any previous surgeries or something?
अपेंडिसेक्टमी हुई थी like 3 years back। तो बट ही डॉक्यूमेंटेड तो कुछ नहीं है। He didn't seem to tell anything like that.
I think this patient should be evaluated. What do you say, sir?
What was his oxygen saturation?
हाँ, ऑक्सीजन सैचुरेशन सर रूम एयर में इट इज अराउंड 95%।
Breath holding time?
हाँ, ब्रेथ होल्डिंग टाइम देखी थी मैंने, इट वाज अराउंड लाइक 15 सेकंड्स होगा सर।
I think we should do nocturnal oximetry.
I also feel the same.
नॉक्टर्नल ऑक्सीमेट्री कर लेते हैं
Yes,
ना
I
सर?
think this patient should be evaluated.
हाँ,
Yes.
ठीक है।
Okay.
Now, so what did we see here? So there is this very famous anesthesiologist, Frances Chung. So during her practice, more than a decade back, she observed that there were many patients who were succumbing to, some sort of adverse events in the post-operative period. There were many deaths, there were many complications. So she launched a survey and she studied these patients. And what did she find? She found that, that post-operative critical events, including death and severe brain damage, not just, respiratory obstruction, were most common when the patient was discharged. And they were least common when the patient was either in the ICU or in the post anesthesia care unit. So, what was happening here? So, what was happening here is the patient's outcome, as expected, were best when the patient was in a monitored environment. So then they further went out and studied what were these type of patients who were having more chances of post-operative adverse events. So they found, the adverse events in form of death, myocardial injury, congestive heart failure, arrhythmias, embolism, stroke, cardiovascular events were all more common in those obese patients who were suffering from obstructive sleep apnea. So that is how they thought of devising, analyzing the coexisting problems, the common factors in these patients, which were binary factors, the demographic factors, and they came out with this very important and very useful score known as the stop bank score. So stop bank score we all are familiar with, and it has been shown that the stop bank score has a very close association with the sleep studies that are there. So, so high stop bank score shows a greater chance that the patient would be suffering from severe sleep apnea. So that is why it is suggested that we all should go out and embrace this scoring system, because it is a very convenient scoring system which can be learned by all who are involved in patient care, including the surgeons, including the nurses involved, so that the system can be alerted that these are the patients who are having high stop bank score. Now, any score that is 3 or more, 0, 1, and 2 are considered as mild sleep apnea. Anything more than 4 and above is considered moderate to severe sleep apnea. So these are the patients who we should red flag, and these are the patients who we should focus on, while we are caring for the obese patient. And when they are found to have any degree of a sleep disordered breathing, then we must know that whether these patients need any more tests. Not all sleep apneics would need, a greater degree of intervention. So we must learn how we can pinpoint which are those factors which should alert the anesthesiologist that, here is the problem. And these are the patients who need to be red flagged. So amongst the stop bank score, any score which has, neck circumference more than, 17 inches or 43 centimeters in men and 41 centimeters in women are the patients who definitely should warn us that there is a problem there. That we are the patients who might have the greatest possible chance of suffering from any respiratory obstruction. Now, let us see what is further happening in this case. So, identifying patients with large neck. So, it is not just about a high BMI, noting the craniofacial features of the patient, then history, like history of smoking, large neck, male gender, advanced age. If the patient is having a coexisting, tonsillar or adenoidal hypertrophy, if the patient has large neck, or if there is a craniofacial anomaly. Now, these are the patients with whom we should, sort of intervene to a greater degree. We cannot take them casually. So noting the craniofacial features is also very important. So this is this very important study that was, conducted in our center only. Here we found that, when BMI is more than 45 and neck circumference is more than 44.5, then chances of, suffering from hypoxemic episodes is much higher in these patients. And when both these factors occur together, then, it has a very high positive predictive value for post-operative events and for them to suffer from hypoxemic. So there are many more scoring systems. Even ASA has devised many checklists. So it is important that we familiarize ourselves with any of these checklists, which which is convenient to us or which we are more familiar with. Now, when we are talking about snoring, then snoring, not just every snoring, when people take, let us say a few pegs of alcohol a night prior, especially men, they, do suffer from snoring. So single episodes, occasional episodes are not the episodes of snoring that bother us. When the snoring is so loud, more than 50 decibel, and how do we know more than 50 decibel? When it can be heard outside a closed door. Neck circumference, which is very large, craniofacial anomaly, nasal obstruction, large tonsils, and patients in whom all these features occur together are the patients who would definitely, we need to work upon. So when do we suspect that, there is a problem? When there is baseline hypoxemia, extremely poor effort tolerance, low breath holding time, patient having dyspnea at rest. These are the patient who may ask, suggest to us that we need to intervene more. So how do we intervene more? Maybe we should do a arterial blood gas analysis to see what exactly is happening in this patient. Is there any, daytime hypercapnia? How much is the hypoxemia? What are the bicarb levels? If the bicarb levels are high, either the patient is having chronic, a long period of recurrent hypoxemia, which is untreated, undiagnosed. So these are the patients we will need to, strictly optimize and subject them to some sort of prehabilitation. And, we'll need to subject them to some intense evaluation. Okay, so if there is any evidence of impaired gas exchange, which can be evident from arterial blood gas analysis, such as evidence of hypoventilation, severe pulmonary hypertension, resting hypoxemia. Patient comes to the OPD, we are doing the pre-op assessment, we can just put the probe. And if at that point patient is having any saturation less than 95, less than 92, less than 88, it should alert us to greater and greater degree that we can take, stronger measures to put them in the safe zone. And all these things in absence of any other diagnosed cardiopulmonary disease. So it is important to find out what is the degree of hypoxemia in these patients. So cardiopulmonary assessment, so if there is pulmonary hypertension, not every patient, every center is having a sleep study. Not everywhere echo is available, especially in our country, where we have, primary centers, smaller nursing homes, where not all facilities are there. A simple ECG showing signs of, right ventricular hypertrophy with or without right bundle branch block, or if we have, a 2D echo which is showing high right ventricular systolic pressure. So all these things would suggest to us that there is a problem. So basic tests are very important. If chest x-ray is showing cardiomegaly, abnormal pulmonary vascularity, signs of heart failure, then definitely these are the patients who we need to be more careful about. So pre-op assessment, we must not forget the basic breath holding time, assessment of the airway by neck circumference, large tongue, whatever. A lazy lethargic patient is definitely symbolic of chronic hypoxemia. Patient having pedal edema, isn't it indicative of right ventricular failure? Definitely there are other causes which might be adding on to the pedal edema. But definitely pedal edema in presence of all these factors should alert to us that the sleep disordered breathing, the severity of obstructive sleep apnea is such that the patient is now in a chronic state, and we need to work to optimize this patient and think of any other tests that can be performed. So what are the other tests? Yeah, so let me invite Dr. Vaishali. She will introduce us to what is nocturnal oximetry and why it is becoming so popular for peri-op management of patients with sleep disordered breathing. Dr. Vaishali Sharma is consultant in the Department of Anesthesia, Max Institute of Laparoscopy, Endoscopy, Bariatric and Robotic Surgery. So over to Dr. Vaishali.
And today I'll be speaking on the topic of nocturnal oximetry. Now, nocturnal oximetry is a continuous pulse oximetry which is done during night time. It has been used extensively in the field of sleep medicine. Now, as we all know that polysomnography has always been the gold standard for the diagnosis and the therapeutic management in patients with obstructive sleep apnea. But nocturnal oximetry has the advantages of being low cost, it is easily available, and it can be done on an outpatient basis. So it can serve as a good alternative to polysomnography for the screening of OSA in patients with a high pretest suspicion. Now, high pretest suspicion is basically based on several scorings. In our setup, we primarily use the stop bank scoring, but other scales are also being used, like Epstein sleepiness scales, which has been used extensively in various studies. Now, how do we interpret nocturnal oximetry? Now, various parameters are there which can be recorded on pulse oximetry. That is, for the time duration the recording has been done, what was the basal saturation of the patient, for how many minutes the saturation was less than 88%, what was the lowest saturation, and the average saturation of the patient. Now, a major parameter which is detected on nocturnal oximetry is the oxygen desaturation index. Now, its decrease of oxygen saturation by 4% or more from the baseline per hour of recording that lasts for at least 10 seconds. Now, there has been several studies that have shown a significant positive correlation between the oxygen desaturation index, which we detect on nocturnal oximetry, and the apnea-hypopnea index, which is measured in polysomnography. So it has proved to be a useful tool as a screening method for OSA in both obese and non-obese patients. Now, as you can see here, it's a normal pulse oximetry of the patient, and you can see that on x-axis we have time in hours, on the y-axis we have the oxygen saturation in percentage. Now, for the entire study duration, the patient's saturation has been well above 95%. This is an abnormal pulse oximetry, where you typically see a sawtooth pattern or the icicles from the rooftop pattern. Now here you can see during this time, the patient saturation has significantly dropped to less than 70%, and it has happened during various phases. Now, it primarily correlates with the REM sleep stage, where multiple episodes of deep oxygen desaturation take occur. Now, this is a summary of nocturnal oximetry. Now, here you can see the various parameters are shown here, like the number of events. Now, the event is the drop in SpO2 by 4%, at least 4% for a minimum duration of 10 seconds. For how many minutes the event has occurred? What is the ODI here? It's 19.4 per hour, and the various parameters as I discussed earlier. Now, this is the graphic summary. Now, on the y-axis, we have the oxygen SpO2. On the x-axis, we have time. As you can see here, between 12:30 and 1:30, there has been a significant drop in the oxygen saturation to less than 70% in this patient. And this green graph is primarily the pulse rate versus time. And the time when the saturation has dropped, the heart rate has also dropped. Now, this is a detailed graphical representation of nocturnal oximetry where the recordings have been done at an interval of 10 minutes each. Now, as you can see here, there have been multiple episodes of significant desaturation to well below 70%. Now, what's the role of nocturnal oximetry in screening for sleep disordered breathing? Now, as has been discussed by various speakers, OSA syndrome or sleep disordered breathing, it's a major public health problem. And it can cause an arousal from sleep, causing multiple problems like sympathetic activation, snoring, fatigue, nocturia, and excessive daytime sleepiness. Also, it's associated with multiple cardiovascular abnormalities and neurocognitive deficits. Now, this is a comparison between the polysomnography, which is the gold standard, and the nocturnal oximetry. So the polysomnography is expensive, time-consuming, labor-intensive. Patients need to be admitted to the hospital, and it requires regular monitoring and expertise for the interpretation. On the other hand, nocturnal oximetry is low cost, easily available. It can be performed on an outpatient basis, and it can be used as a screening method for sleep disordered breathing and to detect patients who need polysomnography. Now, this has been the study by Netzer et al., where he has reported a wide range of sensitivity and specificity for predicting SDB ranging from 31 to 98% and 41 to 100% for specificity. Now, various reasons have been given for it, like there has been the inter-device variability between various pulse oximeters and also variability in how physicians interpret the oximetry tracings. Now, these are the various studies that show a significant positive correlation between ODI on oximetry and apnea-hypopnea index on polysomnography. So, in short, nocturnal oximetry is reliable for screening of OSA in patients with moderate to severe cases of OSA, but it's inadequate for the exclusion of milder cases, which ultimately will need a polysomnography for the diagnosis. Also, it cannot distinguish between the obstructive sleep apnea and the central sleep apnea. So, it's insufficient for the definitive diagnosis of OSA or to qualify the patients for therapy. So, it should be used only as a screening tool for patients with high pretest suspicions. Patients who are found to have suspicion of OSA on various scorings will still need an overnight PSG or home sleep study to confirm their diagnosis. Also, to assess the response to CPAP therapy and the surgical treatment of OSA. Thank you.
So what did we see? Now we saw that, nocturnal oximetry can be very informative. Now the best thing about it is that it can be done even on a domiciliary basis. It can be done at home, So if I'm seeing the patient much in advance, then, patient can be, and it is much cheaper. So the technician comes home, he puts a probe, he goes back. The patient does the normal nocturnal activities and sleeps at whatever time, and in the morning the technician will come to remove the probe, and an SD card can be removed and analyzed, and this can be very, very informative, as we just saw. And amongst other parameters, parameter known as oxygen desaturation index, which symbolizes the number of desaturation events that the patient undergoes per hour. So if ODI is anything more than 4 should put us at alert. Now, these are the patients who we should pick up for further optimization, which can be, we can decide in combination with ABG whether patient needs to see the pulmonologist, whether patient needs to be put, on some sort of a diuresis and, some sort of low calorie diet and a non-invasive support in form of a CPAP or a BiPAP, whichever is applicable to these patients. So it is important to note these findings. So nocturnal oximetry is, also uh, because if we need to pick up the periods of hypoxemia, because if we miss out on that, these are the patients who have higher likelihood of developing even a myocardial event, not just respiratory failure, but also cardiac failure. So when we analyze these simple tests, we get a lot of information, and we can even from medical legal point of view, patient can be, sort of made to understand that they are having findings, which are symbolizing that they have, very poor oxygen reserves, and that we need to together build on the reserves by suitable prehabilitation, which can be even in form of deep breathing exercises. So if we miss out on those things, then these will be the patients who will, have a more exacerbated airway collapse, depressed arousal response, and they would be the ones who would be having intense rostral fluid shifts leading to upper airway edema and reduced airway patency. So it is important to pinpoint these patients. So, and these will be the patients with whom we'll be very, very cautious about use of sedatives and any use of opioids whatsoever. So currently, a lot of centers, including ours, is very strictly following opioid-free analgesia for these patients. So it is important to make note and plan our post-operative period much in advance so that, our patients are in a safe zone. We are able to send them back home safely and give them suitable advice as to how their post-op needs to be managed. So these pulse oximeters or the nocturnal oximetry uh, gives us many more messages, which may not be sort of in the scope of this webinar, but oxygen and respiratory changes during sleep. Nocturnal oximetry report breakdown is giving us a lot of idea about, even patient is hypoxemic in which part of the night, and which part of the night we need to be more careful about, and pattern recognition and use in specific disease entities. So normally we know that, in a normal sleep, the PaO2 would drop by 2 to 12 millimeter mercury, and SpO2 would drop by 1 to 2%. PCO2 would increase by 2 to 8 millimeter mercury, and the hypoxemic and the hypercapnic ventilatory response would be exaggerated in sleep. So, they would be having much increased apneic threshold, a fall in FRC and tidal volume, increase in upper airway dilator muscle, tone, making these patients much more prone to airway collapse. So, by using, studies like nocturnal hypoxemia, we are able to evaluate the hypoxia itself, and by doing that we are able to avert complications like pulmonary hypertension, cardiovascular disease, stroke, CHF, COPD, OSA. In all these parameters, in all these coexisting comorbidities, we can achieve much better outcomes. And not only that, a repeat nocturnal oximetry after intervention or after bariatric surgery can give us a guide about how the sleep apnea improved after achieving a certain weight loss. So adequacy of post-op monitoring is very important. So whether ABG is mandatory in the post-op, not always, we can have a non-invasive CO2 monitoring system, which gives us a fair idea about CO2 retention and when the patient needs a non-invasive support. So it is important for us to familiarize ourselves with these current monitors and not subject every patient to invasive investigations like arterial blood gas analysis. And during emergence, the anesthesiologist has to take care, along with all these measures, that there is proper washout of inhalation anesthetics, there is no buildup of CO2, pressure support ventilation to maintain the FRC wherever possible, prophylactic nasal airway wherever there is nasal patency, and nasal ventilation might prove to be superior to oral ventilation in these patients, and maintaining a semi-upright position is very important. So adequacy of post-op discharge is not complete if we do not familiarize the patient with the warning signs, and we should ensure that the patient has a responsible attendant to look after, and we should have a helpline which is functional 24/7. So the person who's handling the helpline should be able to give the patient the right guidance, and so that person also should be a trained person who's handling the helpline. So with that, let us move on to the next session. So I'm going to talk about analgesia failure and the non-invasive ventilation in the morbidly obese. So analgesia failure in the morbidly obese. Now, morbidly obese patients are extremely vulnerable group of patients because they have very limited physiological reserve, very limited resources of oxygen, and there's a very thin margin of safety between adequate pain control and analgesia failure. So that, of course, depends upon experience and expertise of the involved physicians. So analgesia failure in the morbidly obese has become extremely important. And recently, we all are aware that opioid-induced respiratory depression has been described and accepted as a very, very important um, cause of preventable respiratory depression, brain damage, and death in the postoperative period. And when it comes to morbidly obese patients, this becomes even more important because of their very, very delicate physiology, very, very delicate physiology. So, before we continue our discussion about analgesia failure, let us just have a sneak peek into what is happening in a typical post-operative ward.
बहुत पेन हो रही है सिस्टर।
अच्छा अच्छा, एक मिनट, अभी डॉक्टर को पूछ के बताते हैं ना। हेलो मैम।
हाँ जी सिस्टर बोलो।
मैम, पेशेंट को ना बहुत पेन हो रहा है।
ओके हाँ, तो ट्रामाडोल 50 mg दे दो।
बहुत
ठीक
पेन हो
है
रही
सिस्टर,
है।
अभी 50 mg ट्रामाडोल दे दो अभी।
ओके मैम।
बहुत पेन हो रही है।
बताइए अंकिता मैम। मैम सुनिए,
हाँ क्या हुआ?
पेशेंट को ना बहुत पेन हो रहा है, मैंने पेन भी दिया है, अभी फिलहाल दवा भी दे रही हूँ।
पेन हो रही है, बहुत पेन हो।
जल्दी से 0.5 mg ब्यूट्रन दे दो।
ओके मैम। है हिमांशु, हेलो हिमांशु, क्या हुआ? हिमांशु, हिमांशु सुनो। मैम, मैम के पेशेंट को कुछ हो गया, रेस्पॉन्स नहीं कर रहे हैं।
हेलो, क्या क्या दिया आपने इनको? दिखाइए, हेड अप करिए सबसे पहले इनका। क्या क्या मिला इनको? ऑक्सीजन लगाइए।
ट्रामाडोल
दिखाइए मुझे क्या क्या मिला है।
ट्रामाडोल दिया, ब्यूट्रन दिया।
बाईपैप मशीन लेकर आइए। ऑक्सीजन। हाँ क्या हुआ? ऑक्सीजन लगाओ जल्दी। सिस्टर जल्दी आइए, ऑक्सीजन लगाएंगे। ऑक्सीजन लगाइए इनको, जल्दी आइए। बाईपैप मशीन लेकर आइए। बाईपैप लगाइए, स्टार्ट करिए। मैं ऐसे
So a lot of studies are done and meta-analysis are performed, and there is a lot of literature that is available to enlighten us as to what should be our path. So when do we say that there is analgesia failure? It can have multiple causes. Refusal of the patient to take the prescribed medication. Patient didn't ask for it, so the nurse did not give it. Nurse came to administer the medication. She came and she found that the patient is sleeping. She thought, oh, patient is very comfortable. Let me not give the medication. The doctor comes for the round, says hello to the patient, and patient says, oh, doctor, where were you? For last 2 hours have been miserable. And sometimes there's a lot of mismatch between how the patient is looking and what the vitals are showing. So, this is where the expertise of the physician comes into play, and importance of protocols and training of the nursing and the anesthesia trainees that are involved in taking the post-op care of patient is involved. So the nurse administered the medication and the patient is still complaining of pain. What could be the cause? Improper dosage, improper choice of medications, improper route, or improper technique. So there can be so many points at which problems can occur and ultimately lead to failure of pain management, and consequently we find the patient suffering from excruciating pain. So an analysis was done of post-operative adverse events, and they found that the pain management is responsible for improper pain management is responsible for 34% of adverse events in the post anesthesia care unit. Now that is a very high number, 34%. So what must have gone wrong and what could have been done? Now, coming to this closed claim analysis, which is actually the basis of this lecture that I am taking. Now, here, the study was published recently, and they found that, they studied patients over 7 to 8 years. They analyzed some 20,000 patients, outcomes of 20,000 patients in 165 articles. And what did they find? They found that the pain management related adverse events were there in almost 10,000 patients. They were temporary or minor in 23%, permanent brain damage was found in 22%, and death occurred in 55%. And in all these adverse events, it was improper pain management which was pinpointed as the cause. So, was it wrong medication? Errors were 50%, and improper monitoring. Now, this is a very significant thing, that medication could have been proper, dosage could have been proper, technique could have been proper, but the monitoring was not adequate. So, improper monitoring was found as a very important cause in 30% of the cases. A further analysis of the data, they found that majority of events occurred in patients who were obese, who were carrying a diagnosis of obstructive sleep apnea, or were at high risk of OSA. Now, how do we find the patients who are at high risk of OSA? They had done the assessment using clinical scoring system like the stop bank scoring system, using the patient's BMI with more than BMI of 35 were taken as morbidly obese patients, and they used all other uh, factors that contribute to the stop bank scoring system. And they found the patients who had stop bank score of 3 or more were definitely very, very prone to respiratory depressant effects of the pain management techniques. So the medication related errors were in the form of continuous infusion of opioids, interaction of opioids and non-opioid sedative medication. Now, what pre-medication I give? Did I give Alprax? Did I give midazolam right in the beginning? And my surgery finished in 1 hour. Patient was still sedated. Patient could have come out of the inhalational agent or a propofol infusion or a dexmed infusion, but there was a lingering effect of the midazolam that was given right in the beginning. So I made a wrong choice of medication and I did not care. I administered opioid and there was a summation of effects of both the medications. So this was found in 31% of the patients. More than one physician prescribing a medication was seen in 30% of the patients, and excess opioid was only in 15% of the patients. So even if we are careful about the dose, if I'm not careful about who administered the last medication, how much time has elapsed since the last medication was given, what was the medication, what was the dose. So definitely the person who is responsible for post-op pain has to take into account multiple factors. So when it comes to obese patients, definitely continuous infusion of opioids is an absolute no-no. Interaction of opioids with non-opioid sedative should definitely be red flagged and highlighted, and care should be taken. Everybody who's involved in the perioperative care must be mindful So the person who's handing over the case, person who has conducted the case and is handing over to the person in the post-operative period must pass on the message about what was the pre-medicant and what were the medications that had potential to cause sedation that were administered to the patient. So everything contributes to the medication error. Now, the type of opioid co-administration of non-opioid and sedating drugs, supplemental oxygen immediately before the event, the opioid dose is excessive these were found as the confounding factors in multiple studies. So, what are the criteria for definite analgesia failure? When do we say that the respiratory depression is because of the analgesia failure? If a patient has received naloxone or showed evidence of reversal of failure after administration of naloxone, then it is definitely an analgesia failure because of opioid overdose. If the patient is showing objective signs of opioid toxicity, which could be in the form of oversedation, pinpoint pupils, respiratory arrest, non responsiveness, or very shallow breathing, so definitely we should think of resuscitating the patient quickly and administering naloxone as quickly as possible. So both the factors would contribute to analgesia failure due to a poor analgesia protocol. And what are the criteria for probable analgesia failure? If the respiratory rate is less than 8, if there is somnolence, if the SpO2 is less than 90% in the postoperative period, with, of course, presuming that the normal SpO2 was less, patients showing pinpoint pupils, high dosage of opioids in opioid naive patients, qualitative observations in the form of snoring, AV obstruction or cyanosis, intervention, if the patient has required intervention in the form of a jaw lift, a positive pressure, mask ventilation, or reintubation, definitely everything adds to analgesia failure. So let us see an ideal scenario.
Sister, bariatric patient is coming. Keep the bed propped up. Start this. Keep the BiPAP also ready. Plus oxygen also.
Yes, ma'am. Sure.
सिस्टर मुझे पेन हो रही है सिस्टर
मैम
मुझे पेन हो रही है
मैम पेशेंट को बहुत
सिस्टर
पेन हो रहा है
पेन हो रही है
Give him Flamazac 50
ओके
over 20 minutes.
ओके मैम मानसू अभी ठीक हो पहले से बेटर है
सिस्टर अभी भी पेन हो रही है
मैम
Yes,
पेशेंट को
sister.
स्टिल अभी पेन हो रहा है अभी भी पेन किलर हमने दिया हुआ है
दिया है. What has been given to the patient?
या हम इंजेक्शन ट्रामाडोल गिवन
Okay.
5 मिनट पहले ही दिया था
5 minutes.
Yes, ma'am.
Then let us wait for 10 minutes.
ओके मैम
हिमांशु जी, अभी हमने आपको पेन किलर दिया है. आपको 10-15 मिनट में आराम आ जाएगा. Okay? Don't worry.
So planning starts right in the pre-op. Right in the pre-op, my instruction as the chief anesthesiologist has to be what medication should not be used as a pre-medicament. So definitely benzodiazepines are out. I can use things like dexmedetomidine, which are shorter acting, have minimal effect on respiratory system of the patient, and are quick to terminate. So whatever are the choice should be conveyed to all the team members. So the preparation starts right in the preoperative period. Any patient in the preoperative period who has been found to have any factor, which is a high risk for OSA, as we have just discussed, or is having OSA, may be diagnosed after a sleep study or with a high stop bank score, definitely should be red flagged. And more than one opioid modality in that patient should be avoided as much as possible. More than one physician prescribing opioids or a non-opioid sedative medication should definitely be strongly discouraged. So there has to be a continuity between the person who is conducting the case and the person who is taking care of the post-operative period. History of chronic opioid abuse, timing in minutes between the last nursing check and the respiratory depressant event should always be documented. So if I am walking into the post-operative period and the nurse calls me that, ma'am, please see that the patient is in pain, it is my prime duty to find out what are the pre-medicants that were given, when was the last analgesic, is there any special instruction from the person who conducted the case without having all these informations has sufficient time elapsed after the last opioid administration. So all this needs to be checked at the time of administration of the analgesic. So what are the criteria for possible opioid related adverse events? Patient found in cardiopulmonary arrest without any other identified cause, patient receiving significant amounts of opioids, patient snoring in the postoperative period, loud breathing or somnolence or shallow breathing or non-responsiveness all will contribute to the diagnosis of opioid related adverse event. Now, looking at yet another study that was published in a very renowned journal, Chest, where they found association of sleep disordered breathing with postoperative complications. They found that all complications, be it respiratory, be it cardiovascular, be in the form of post-op bleeding or any GI event, are all related, are very, very high in patients who have a diagnosis of sleep disordered breathing. So we have to be very, very cautious in selecting patients, and patients who have been identified to be having a stop bank score of 6 or more will definitely be patients who are very, very vulnerable to post-operative critical events, and special attention should be paid to care, post-op care of these patients. Now, sleep disordered patients with sleep disordered breathing will also, actually behave differently. There will be two broad types of patients who have sleep disordered breathing. One would be those who have sleep fragmentation, then the other will be those who have intermittent nocturnal hypoxemia. So when I am taking care of a patient, I must make note of what is the type of sleep disorder that the patient is having, because the requirements of the post-operative pain medication and response to it of both the type of patient will be very, very different. Patient with increased risk of opioid related respiratory event, then there will be patients who have altered pain perception. Patients with intermittent nocturnal hypoxemia will have increased opioid potency, reduced opioid requirement, and hypoalgesia. Patients who have sleep fragmentation will have higher inflammation, post-op inflammation, spontaneous pain, enhanced pain sensitivity, and hyperalgesia. So we must make a very careful observation of how the patient is presenting and what is the type of sleep disorder that the patient is suffering from. There's a very delicate balance that exists between the two, and anesthesiologist has to play a very, very vital role in deciding. So one patient may have some component of both, sleep fragmentation as well as intermittent nocturnal hypoxemia. So while I am deciding the post operative pain management, I need to make a very delicate balance between the two. Sleep patterns in the post operative period definitely need to be documented and carefully observed. So they are affected by the surgical stress, anxiety, pain, disturbance in sleep architecture on the first day, reduced total sleep time, sleep deprivation, and suppressed REM sleep fragmentation on first 24 hours. So these are the patients who might land up in a rebound increase in REM sleep in after they are discharged from the hospital. So coming to another set of problems that we may encounter. Well, nursing checks are very, very important. Nurses play such important role, and the trainees, anesthesia trainees who are taking care of the post-op play a very important role in assessment and forwarding the exact situation to the seniors who might be involved. So we need to have a very constant dialogue with them. So this was a very, important and critical scenario that was published in the same closed claim analysis, where in the post-operative period, a nurse was taking the round, and she found a patient who was a little sleepy, slow to arouse, snoring loudly, and the saturation was 49%. So she thought she should, connect the oxygen quickly. She came and she connected oxygen. She waited for some time. She saw that the oxygen came up to 99%. So she did not think it important. She thought she should not disturb the doctor, and she left. Very soon, she got a call from the patient's attendant who came running that the patient is not responding at all and not taking any call. So they came running, they raised a rapid response team, the doctor came running, and they found that the patient was no more. So, what must have happened? So, the sisters' first response should have been to check the end tidal CO2. So, monitoring the post op carbon dioxide levels is also very important. So it's extremely important to have, a CO2 analyzers even for the post-operative period. Patient can be put on continuous capnometry also, and the attendants can also be educated to take care of the monitors and the parameters. So if we have a figure something like this, patient rather needs a non-invasive ventilation rather than oxygen. So by doing connecting the oxygen, we eliminated the CO2 drive, the hypoxemic drive, the somnolence in deepened, CO2 built further, it became a vicious circle, and the patient went into a non-arousable state. So when I have a patient who is sleep apneic and who is showing a tendency to high CO2 level in the post-operative period, definitely a non-invasive device should be standby, and the person who's the nurse and the trainees who are taking care of, they should know how to connect it, and at what level they should quickly connect it. So supplemental oxygen versus a positive airway pressure support is very, very important. So a delicate balance need to be found. So supplemental oxygen is required only till we come to a baseline level of SpO2 is achieved. After that, if the EtCO2 is high, we will have to connect a positive airway pressure support. So availability of a non-invasive ventilation device or a BiPAP device is of paramount importance, and we will learn definitely in greater deal in the subsequent lecture. So the nocturnal oximetry has a very significant role. Identify and document the baseline SpO2 right in the preoperative period. Determine the hypoxemic period. So, we don't need to have a detailed sleep study, even a simple nocturnal oximetry, and we must know what all to note down from the report of the nocturnal oximetry. It helps in achieving the PAP titration and in prognosticating. So as far as medical legal issues are concerned, whenever we have ordered for nocturnal oximetry, we must document in our anesthesia chart or in our computers these important parameters. Outcomes. Post-operative outcomes are an interplay of in the invasiveness of surgery, compliance of non-invasive ventilation, timing of an IV, any requirement for opioids, and the severity of OSA and obesity. Analgesia failure, risk reduction strategy should be very, very much in place. We have to limit the dose of intraoperative opioid, multimodal analgesia, and inclusion of regional analgesia in our technique as much as possible. Look for opioid-induced respiratory depression, educate the people, do not hyperoxygenate, continue the NIV till the return of normal sleep patterns, and make a very careful note of presence of somnolence. Strategize the post-operative pain and use the screening tools. We may not have a detailed sleep study available. So the screening tools should be in place, and we should be familiar. Everybody involved in the team should be familiar with the usage of those screening tools. Naloxone should always be available in the post-operative period. Training the post-operative care providers is very important as the documentation. So the availability of NIV is a insurance against the catastrophes. So maintain a dialogue with all team members. So with that, I will conclude this lecture and we'll move on to the next lecture by Dr. Vikas Mittal, where he is definitely going to give us tips on how we can tide over this periods of hypercarbia and hypoxemia in the postoperative period. Thank you. After having learned the assessment of patients with morbid obesity who are suspected of having sleep disordered breathing, and learning the finer aspects of pain management in the postoperative period and how to make the whole peri-op experience a safe experience for the patients. We are now moving on to the final part of this CME, which will be conducted by Dr. Dinesh Punhani. Dr. Dinesh Punhani is director and a senior teaching faculty in Max Institute of Laparoscopy, Endoscopy, Bariatric and Robotic Surgery. So with that, over to Dr. Dinesh.
Okay, so till now, through various videos and lectures, we have learned, the importance of pre-anesthesia assessment, importance of clinical tools to assess the sleep disorder breathing, even in the absence of advanced investigation like PSG, and moreover the importance of communication, or I would say how lack of communication can lead to failure or mismanagement in the post-op period, leading to analgesia, failure, and other respiratory events. Now, in the next lecture, we will learn how to optimize or prepare the patient with sleep disorder breathing, and when or how to use non-invasive ventilation like CPAP or BiPAP. And to talk about all this, we have with us Dr. Vikas Mittal. Dr. Vikas Mittal is Associate Director in the Department of Respiratory Medicine in the Max Hospital, Shalimar Bagh, Delhi. So over to Dr. Vikas Mittal.
Namaskar, everybody, and a warm welcome. First of all, I would like to thank Dr. Aparna Sinha for doing a wonderful job in continuing this bariatric anesthesia CME, and she's doing a wonderful job. I've worked with her for many years, and today she has asked me to give you some tips to manage post-operative respiratory failure in morbidly obese. So let's talk. Severely obese patients are at high risk of post-operative respiratory complications. Why? Why? Because they have associated obstructive sleep apnea and obesity hyperventilation syndrome, which is because of a narrow, smaller airway and chronic hypercarbic respiratory failure. Now, OSA is extremely common, and in one series, more than 70% of the patient who underwent bariatric surgery and had polysomnography was detected to have obstructive sleep apnea. Most of these respiratory complications occur within 24 hours, and so a vigilant monitoring is critical, and this is what we are going to talk about today. So how do we do it? In post-anesthesia care unit, we monitor respiration and ventilation. And why is it important? Because in a study, in cases reported to obstructive sleep apnea, death, or near miss registry, most of the brain damage and death were when there was no were less common when there was a respiratory monitoring, or when the patients were given supplemental oxygen. So it is important to monitor. And how do we do that? We do that by doing a continuous pulse oximetry in patients with obstructive sleep apnea, or in if any obese patient. And this is important to monitor the patient when left unstimulated, because the obstructive sleep apnea patients, when awake, will not have desaturation, but when they are sleeping and left unstimulated, their oxygen may go down. And we do a ventilatory monitoring by either our clinical means, by monitoring the respiratory events, by seeing desaturations of oxygen going below 90%, or a respiratory rate going below 8 breaths per minute, or when we see a apnea of more than 10 seconds. And we can do, if we have available, it's a very good tool, a capnographic, which has high sensitivity and rapid response time for detection of respiratory depression and hyperventilation. But it may have a low sensitivity in an awake patient versus a patient which is intubated. But still, it is a great tool. Arterial blood gases should have a low threshold in getting an arterial blood gas, because it gives us a good quantitative assessment and needed. So let's talk about some pitfalls in and some points in monitoring. See, this is a pulse oximeter normal waveform, and we can see if the waveform is if the patient is having low perfusion, the waveform will be low, but and the reading may be inaccurate. And this is especially important for the respiratory nurse or the ICU nurse to identify these artifacts, because when these artifacts are there, the reading of the pulse oximeter is not important. Um, uh, I would like to just put a small point here about nocturnal oximetry, which is commonly used by bariatric anesthetists and to screen their patients for hypoapneas as well as for obstructive sleep apnea. Though it is not a very good tool to monitor to diagnose a patient for obstructive sleep apnea, but still it can give us an oxygen desaturation index, which usually correlates with apnea hypopnea index. And another important thing which gives which nocturnal oximetry gives is a percentage hypoxic burden, which is a percentage of oxygen of a percentage of the time spent below the saturation of 90% or 85%. So if it is if the percentage is quite huge, so if it is more than 1%, then it is significant. But if it is if I say if more than 50% of the time patient is spent below 50%, then it suggests that there was some hypoventilation, and we should be monitoring the patient more closely. Now, how does a capnograph look? This is how a awake patient capnograph probe looks, which actually takes a small sample of expired air and samples it. Mm, and this is how a normal CO2 waveform will look. And the normal value of end tidal CO2 is between 35 to 40 millimeter of mercury. And these are the different waveforms, the normal waveform, and I would like you to concentrate on these three hypoventilation waveforms of end-tidal carbon dioxide capnographic waveforms. So when there is increased amplitude and width, then the patient is breathing at a less rate and maybe less. This is called dyspneic hypoventilation. But if the patient is breathing normally, but the amplitude is decreased, then it is hypoapneic hypoventilation. These are another few waveforms of curvy waveform may suggest a bronchospasm, and a loss of waveform suggests apnea. Now, ABG is precise, and it really helps us in knowing whether the patient is having acute hypoventilation, acute on chronic, or a chronic hypoventilation. A complex graph, not going into details of these, but just see these two curves. So, a patient with acute respiratory acidosis may have an arterial pH uh, between 7 to 7.15, and anybody with the chronic will have something between 7.2 to 7.34, and may have a normal pH also in case the patient is compensated. And somebody with acute on chronic, it will be pH will be in between. And if we see this in acute, the bicarbonate will not go above 25 to and maximum 30, but in a chronic the bicarbonate may go above 30 and maybe touching 50. So this is just few clues. You have to still calculate the proper estimated um, bicarb and estimated carbon dioxide as per the ABG analysis algorithm, and to really know if there are mixed acid base disorder. Now, how do we manage the patient? We have known the monitoring. Now, let us know how do you manage a patient who is hypoxic. So, if you see a patient going into hypoxia post-op, we give oxygen, and it not only provides respiratory support, and it overcomes obstructive apneas in obstructive sleep apnea. And in some series, it is known that those patients who are non-compliant with TAP and those they may do okay with an oxygen supplementation, but the caution here is that oxygen may worsen hypoventilation. Okay, and so you should be aware if the patient has a concurrent obstructive obesity hypertension syndrome or a COPD. And the risk factors for CO2 retention, there is no ideal way to know it, but a history of CO2 retention at baseline, this is important. And when we see an elevated bicarb, so this will raise our suspicion of the patient may have a concurrent OHS. If this is and a low initial pH and oxygen will also alert us for the possibility of patient having a hypoventilation. Now, how do we, apart from oxygen supplementation, what else we can do? We can do a positioning, head-up positioning, or lateral positioning if surgically acceptable, and incentive spirometry every 15 minutes. And if also if the patient is compliant, a CPAP or an NIV may help in improving the oxygenation if it is unresponsive to incentive spirometry and oxygen. Now, important point is oxygen should not be used alone in a patient who has suspected obesity hypoventilation, as oxygen may increase hypocapnia by worsening the altered chemoresponsiveness. So, what are the treatment options for these patients? So, the treatment options are three. Understand that we can, it's not only the NIV or mechanical ventilation, we can treat these patients of overlap syndrome and hyperventilation with fine titration of oxygen. But choosing among these options will require a pulmonologist or intensivist help. So, but how do we do it? So we the primary goal is treatment of hypoxemia and avoidance. Secondary goal is avoidance of hypercapnia. The aim is for a saturation of maintaining a saturation of 90 to 93% and a PaO2 of 60 to 70 millimeter of mercury. But in a sick patient, in a patient who is having chronic hypoxemia and chronic type 2 respiratory failure, then a saturation below 90, like maybe 85 to 88 is also okay, up to 93%, and a PaO2 of 55 to 60 is also okay. So basically, why this target is given, because a patient, so this is an oxygen hemoglobin saturation curve. So in this part of the curve, like when the partial pressure of the oxygen is between 50 to 70, you see the saturation is which is actually important for tissue oxygenation. The saturation is between 90, 88 to 90%. So how do we titrate? We start with a low flow oxygen and increase it every 5 to 15 minutes by 1 liter or 4 to 7% via Venturi mask. So a patient with no VQ mismatch, we can increase it every 5 minutes, but a patient with significant VQ mismatch, we should increase it slowly over a period of 15 minutes. See, understand titration only works when the response is quick within 15 to 20 minutes and there is no evidence of complication of hypoxemia. We should not be titrating when we should not be titrating if the patient is going down and the small amount of this titration is not helping and the patient is going down. And prolonged hypoxemia can aggravate tissue hypoxemia and worsen acidosis. And we should not actually stop oxygen at the cost of preventing hypercarbia, because if we stop the oxygen, the patient may go into worsen. It may worsen the acidosis. And between Venturi and nasal cannula, I prefer Venturi mask because Venturi mask permits tight regulation of maximum FiO2 delivered. Because in a face mask or oxygen, the flow required is entrained by the air coming into the mask. But in a Venturi mask, the flow required by the patient is actually is taken by the patient, and it is not dependent on the patient's ventilation, because the air escapes through the mask rather than entering into the mask. So when the oxygen is low, quite low, and then we don't increase it, titrate the oxygen slowly, but we can give directly the FiO2 to target SpO2 of 90 to 93%. But when above this thing also fails, then we should give, and the patient is having acidosis but minor symptoms, then we should give NIV. But if the patient is having severe acidosis or marked depression and consciousness, then intubation and mechanical ventilator is definitely needed. Now, how do we give a ventilation or a PAP or an NIV therapy? In a patient with known obstructive sleep apnea and who is been compliant with preoperatively with PAP, we should continue and ask the patient continue the patient's own CPAP. This helps the patient be more comfortable as he is been using his own CPAP. So it is always wise to ask the patient to bring his own CPAP. For a patient with suspected obstructive sleep apnea, but having not done a sleep study, or a patient who has been diagnosed with sleep apnea but not compliant with PAP, you can continue to use oxygen, but watch for hypoventilation as we have discussed in the previous slides. And if the patient is having hypoventilation, then definitely a PAP will be needed. And so where should a PAP be applied? PAP can be applied even in the wards, floors, and obviously in post anesthesia care unit, and should be applied always when the patient is asleep, as well as when the patient is asleep in the daytime. And the patients who are having hypoventilation may need it in the daytime, but it should be monitored closely as the hypoventilation will also improve with the use of daytime NIV. What are the settings which are needed? The settings which have been previously prescribed should continue, but you should make some adjustment if the patient is having like airway swelling and there is edema, there is fluid shift, or if the patient is on opioids. If the previously prescribed level is not known, we can start with an empiric 8 to 10 centimeter of water and may titrate until all the apnea, desaturation, and snoring are eliminated. Alternatingly, it is wise to invest in an auto CPAP titrating machine, which actually helps in taking care of the apneas on itself. If there is a concomitant obstructive obesity hypoventilation syndrome or a hypoventilation disorder like COPD, or the patient is on opioids and developing hypoventilation, then he may need a bilevel ventilation with a spontaneous or a time mode. Now, how do we take care of a patient who is intolerant to PAP? What are the few tips which we can do? We can invest in variety of masks. Actually, the major problem with non-compliance with the PAP is usually because of poor patient interface. So now there are variety of masks available, a nasal mask, which can be a nasal pillow, and which can be an oronasal mask which doesn't sit on the nose bridge. So these are different and different masks, and it is good to invest in variety of masks and have that in your post-operative anesthesia care unit. So important thing which makes you intolerant to PAP is a nasal blockage. So when there is a nasal blockage, you should not be using a nasal mask. You should add a heated humidification which decreases nasal stuffiness, and you can add a saline or a steroid nasal spray. High leak is another troublesome thing which is there. So you can decrease the pressure range if you have put an auto CPAP. This decreases the leak, and adjust the mask, and maybe change the mask. If there is a mouth breather, then nostril mask should not be used, and the high leak because of mouth breathing can be taken care by using an oronasal mask. If there is excessive pressure complained by the patient, then a pressure ramp can be put. If the patient is claustrophobia, that's the most real difficult situation, and a counseling and desensitization is needed, which requires little time. And aerophagia can be taken care by adding a prokinetic. We can help a patient, we can do a good monitoring of these patients by having a software which can be taken by the different companies which are providing you these CPAP machines under the PAP machines. They all of them have a software which can help you monitor your patients so which can give you a summary graph of the usage of the patient and a detailed graph. And if we use oxygen adapter to the machine, then it can give you oximetry statistics. So this is the usage of the patient over a few days, and the AHI over the days, and the pressure and the minute ventilation. You can so in a post-obstructive care unit, you can do this and see the detailed analysis of the day by going into the detailed graphs. It gives us a very good overview of SpO2 if we use an oxygen adapter, and give us it can give us minute ventilation, tidal volume, and if we really expand the x-axis and see, we can see the patient events as well as any apneas, etc., happening during this thing. And this is how a compliance printout will look. It can give you usage, leak, AHI events, SpO2 if we are using an oxygen adapter, tidal volume, respiratory rate, minute ventilation, leaks, pressure, events, everything can be given. Now, how do we discharge a patient who has been monitored? So those patients who have severe OSA, non-adherence to PAP, and significant OSA-related comorbidity should continue to be monitored till they are compliant with their PAP, till their oxygen improves. So initially we should use it only during if the patient is having hypoventilation, then we should use the PAP during the daytime. And there is no rule to how do we taper a non-invasive ventilator, but what we usually do is we give a patient who is sick NIV every 2 hours, every 4 hours, and 2 hours off, 2 hours 4 hours on, 2 hours off, 4 hours on, 2 hours off, and continuously during the night. The patient is getting better, his mentation is getting better. Then what we do is we give the patient 4 hours off and 2 hours on, and continue during whenever they are asleep. And when the patient is the pH has become normal, the patient is more awake, then he's compliant with the PAP, and overall he's improving. Then we just give it during the sleep, and during the sleep, whether it is day or night. Remember that the patients with obstructive sleep apnea, there is disruption of sleep architecture, which can lead to increase in AHI for a minimum of 3 days post-op. So we continue to avoid sleeping supine positioning if possible, and maintain CPAP use whenever asleep, including daytime sleep. This is all what I usually have to say about this thing. There are two more slides on ventilatory management. When the patient is sick and may need a ventilation, then if the patient is ventilated, then to improve oxygenation, we use PAP and give PEEP during spontaneous respiration. But if the patient is is sedated, then we have to assist with pressure support and or may need a control ventilation. And when we give a control ventilation, we should try to use a lung protective strategy by giving a tidal volume between 6 to 8 per kg idle body weight, and adjust respiratory to maintain normal apnea. Limit FiO2 to maintain oxygenation between above 90, and this is to prevent absorption, atelectasis, and oxygen toxicity. Individualize PEEP to optimize plateau and driving pressure, as well as lung compliance, and follow open lung concept of ventilation. So a patient requiring prolonged ventilation we should see if the patient is requiring prolonged sedation or opioids, then they should not be. Most patients will be extubated within 24 hours, but if they are having respiratory and cardiac complication, then they may require prolonged intubation. We should continue our lung protective strategy ventilation with giving initial tidal volume of 8, and if there is ARDS, then 6 ml per kg idle body weight. Then subsequent settings are determined by peak airway pressures and arterial blood gas. Relative pressure should be maintained below 35. Addition of a good PEEP may improve lung compliance by reversing atelectasis and increasing functional residual capacity. And early tracheostomy should be done if we are expecting a prolonged mechanical ventilation. This is all I have to say, and little theoretical lecture, but I will be happy to answer any questions and queries from the audience. Thank you.
Thank you, Dr. Vikas. That was like a very elaborate and very informative lecture. And with that, we come to end of the lectures, and we would be happy to take any questions if there are. How to use naloxone, dosage in obese patients, and if we are going to repeat the dose, how frequently and maximum of how many doses by Dr. Lavanya. Yeah, so that's a very pertinent question. So about the dosing, one thing that we have to remember is that, dosing depends upon not the absolute body weight, but the ideal body weight. There are some medications for which we can use adjusted body weight, but for naloxone, ideal weight should be fine. So whenever we are, giving anesthesia to a patient, we have to have a mental picture of what is the ideal body weight of the patient. So we stick to the same dosage as we follow for non-obese, but keeping ideal body weight in mind. So 1.5 to 3 microgram per kg should be the dose. But for practical purposes, how we do it is, number one, it should depend upon what agent has been used. Is it a short-acting agent like fentanyl or a long-acting like morphine? So mostly morphine is almost obsolete when it comes to obese patients, so that we hardly ever use. Mostly it is fentanyl only. So we, dilute the 400 mcg in 10 ml and give in aliquots of 40 mcg at a time, and not to be repeated earlier than 2 minutes. So we wait and see the response. And if we do not have an IV access, then, the whole ampule can be given intramuscular to a maximum of 10 milligram over 6 hours intramuscularly, and not more than 4 milligram in 6 hours intravenously. So I hope that answers the question to Dr. Lavanya.
Good evening, everybody. At the outset, I would like to thank the team who has presented this excellent webinar, the very high-tech, as I would call it, the webinar today on obstructive sleep apnea, evaluation to safety, by none other than Dr. Aparna, who is completely dedicated to this specialty, I must say. And it is actually a subspecialty of anesthesia. And I know they do plenty of these morbidly obese patients in their practice. So definitely the tips that have been given to us by them, and also the case scenarios and other parameters, have been very, very informative. Thank you, Dr. Aparna, and your team who participated with you, Dr. Vaishali, Dr. Abhishek, Dr. Vikas, and your whole team. That is really a very informative webinar. So Aparna, thank you so much. We really enjoyed the webinar along with your whole team. And thanks a lot to the participants. Thank you, Sanish, for being there. And thank you, Dr. Radhakrishnan, who could not be there today, Dr. Muralidhar Kanchi, Dr. Baljit. And thanks a lot, Clarinet and Faraz, for this all coordination. And we'll be seeing you next week at the same time for the PG Assembly, as Dr. Sanish had told us.